Okay, our last speaker is Dr. Nilesh Balar. What I would suggest the panel to do is, there's 1, 2, 3, 4, 5. Just rate 1, 2, 3, 4, 5, so that then Dan and I have no problems after that. Okay,
let's not wait too long before the drink starts. And I will need one after this for sure. So this is typical. She's a 90-year-old lady who came into the hospital on the Friday. It was seen by my partners. They had reviewed the case, and as usual, she got the workup done, cardiac and everything else. She had a thoracic aneurysm, which I will show you. It is a saccular aneurysm. She got cardiac workup, echo, and everything, and she was scheduled for Tuesday. And since it was all planned, I was assisting in this case. These were the findings: 6.6 saccular aneurysm, just distal to the origin of left subclavian. Since we are all surgeons, let's look at the image. So that's the aneurysm. These were some of the excess vessel, but that was the smallest on the right side. This is what the picture looks like. My question is it something that you would treat? Or is it something that should be managed conservatively?
So let me get this. So 90-year-old,
90, yeah.
asymptomatic?
She has complaints of pain, left shoulder and back pain.
Is she functional?
Yeah. Yes, she is living by herself, totally functional.
Yeah. I think if she's functional with that size of a saccular aneurysm, I certainly would offer her treatment. The one question I have is that a vertebral that's coming off of the saccular aneurysm?
No, I think
No,
Looks like a mammary.
yeah.
Okay.
Looks like a mammary. I mean, I think if you have a discussion with her, this is not something that's going to make her better.
No, we had a long discussion
Just
with the
gonna-
family,
Yeah.
the patient,
And I think
and
that's- yeah.
extended family. There are like 5 people coming in.
Yeah.
And we had clearly discussed that options are either we leave it, it's 6.6, it is saccular, it has a risk of rupture. If it ruptures, there's not much we can do, but if you want, there's an option to be treated, and we planned it. And the plan was, since there was a little room, we had the access, as you can see from the left arm. We put a wire, so in case if we have to put a chimney, at this stage, we didn't plan to do carotid subclavian. She's almost 90 years old. She's functional, but didn't want to do a whole lot. Anyway, moving forward. Yeah. In this case, I think probably about 1 or 2%, because the lumbar and spinal cord ischemia also was discussed. A lot of things were discussed, but in this one, why would you think so?
Just because of the aorta, the way the aorta looks at that.
Okay, could be. Aorta was crappy, I agree, but we didn't have much of an issue in terms of that.
So your plan was just to use a single piece, cover the subclavian, or a single, what do you call it? Single branch graft, or just?
No, so we ended up putting 2 stents covered, and since it was such a large aneurysm, when the first stent was deployed, as you can imagine, it moved into that, so we had to extend it with another stent, and there was the chimney from the left subclavian.
So there are 2 thoracic pieces.
Yeah, 2 thoracic pieces, and that was 22 French Medtronic device bareback. We went in, we put the first one, pulled out, went second time, put the second, pulled out, had the other stent deployed, and this was the completion. Now, in order to iron it out, we used the 20 French sheath. The other one was 22 bareback. Now we had the 20 access, and then we ballooned that. And this was done with my partner on the right side. On the way out, now this sheath is stuck. So we pulled out the left subclavian, was okay, because anyway, that wasn't going to help us figure out what to do because of the extension that we had. So now we are stuck. The question is, it looks like it's at the external. We shot the picture. So it's at the junction of common and external iliac artery. So she is an elderly lady. She was not very big. So plan was to control both the side iliacs. I didn't want to put a very large sheath on the other side. So 2 balloons on either side. And probably it was easier to extend the incision or cover and close it first. So either way, we had the control, we took the pictures. We debated if we could put a stent, but hypogastric is right there. So I wasn't very sure if we would be able to control the hypogastric. If the external iliac comes on a stick, there's no way of controlling the hypogastric on the other side. So decision was to put 2 8 balloons and control the common iliac on both sides, and then control the external iliac. And interposition jump graft, because she is not that big a lady. We had a covered stent ready in that area. We had 2 balloons. Once we pulled out, we put the balloon between the time that we had the sheath pulled out and the balloon inflated. There was about 2 minutes of hypotension. But she came back, nothing much, and she was stable after we put the 2 balloons up. And we had the groin incision extended. We controlled the common iliac. This was the artery on the stick. We had used the balloon with the stent to use it as occlusion if it was going to hold any bleeding at that point. But anyway, long story short, we did the interposition graft. This was her external iliac, junction to the common iliac, and then bypass was done. So this was her extended incision from the right groin to the external completion angiogram. So this is all done, looks good. Patient is stable, was sent back, extubated. Total hypotension was just about 2.5 minutes. Her H&H was stable. She remained hemodynamically stable. We go to post-op day number 1. She complains of, we had the spinal drain that was removed the day after at around 2 o'clock because she was extubated, moving everything. Once it was removed, she started complaining of leg pain and numbness with some foot drop. Weakness in the right leg signal, heparin was started. We did the duplex. We're still worried whether it's the spinal cord ischemia versus leg issues because she is 89. Her outflow was not the greatest. Her ABIs were not the greatest, but nothing bad on the initial angio that we had taken on completion. So post-op day number 3, since we could not figure out what was the issue, we got the MRI, the CT scan. What would you do at this point if you have a patient post-op when you have covered not too much, just 2 stents, you're not all the way down, you had left subclavian, complaining of numbness in the right leg, which was the leg that we had treated. Options would be either you're thinking of neurologic deficit, spinal cord ischemia, right leg related, because she has a foot drop after about 48 hours on the right leg. So we called the neurosurgery, we called the neurologist, we got the MRI to see if there was any evidence of spinal cord ischemia. There was cauda equina syndrome, but no bleed, and there was no other issues. We shot an angiogram just to make sure we are not missing anything. So we went from the left leg, shot up and over. Both legs were visualized fully. These are the images. It's not the greatest vessel, but it wasn't anything that was bad, at least from the pre and post. We put a spinal drain just because nobody was very sure whether there was spinal cord ischemia or not. So fast forward, another day goes by. She gets better with heparin. She's moving a little bit here and there. The pulses are not palpable, but foot is warm, good capillary refill.
So I'm going to stop you. We had a couple of patients who had this problem where they developed neurologic symptoms. You don't really understand the relationship. You've covered a short segment of thoracic aorta. Honestly, I'm not even sure I would have put a spinal drain in. But she's 90 years old, and you're thinking about her thoracic and lumbar spine, but she can also have cervical spine disease. Like, you need to look through her entire spine to make sure she doesn't have something that's doing this.
You're exactly right. We had everything. So we looked at, she had cardiac equina syndrome with L3-4-5 fracture or compression. So that was probably the reason, but just because we had to be positive, so we called the neurosurgeons, we called the neurologists, we had all the consults, and that's what they kept on. And we added a drain for at least another 24 hours, spinal drain. We removed because there was no evidence of spinal cord ischemia that we could substantiate. So now this goes on.
Why couldn't just this be a circulation problem? You
We
know,
did
the
the
foot drop
angiogram.
on, right to the toes?
Yeah, all the way down, both the
But you said she
angios.
had no palpable pulses, no signal?
No, but a capillary refill, she never had palpable pulses to begin with.
Okay.
But she had good
Signals.
capillary and good flow. I'll show you what keeps on happening. So there was waxing and waning. We put her back on heparin. We are puzzled that what's going on. We have been looking at her. Some days she claims that her leg is feeling good. Some days she's like not so good. And she had right side, she couldn't lift the foot. So she had a foot drop. And we couldn't figure out what was the reason, because even if you go to the external iliac exposure, you still can't get to the nerves. So that's not happening. And angiogram clearly showed there was good flow on that side. So on day number 9, she had worsening of her left leg. This is the other leg, not the right leg. That has the problem. So now she complains of acute pain, so we took her to the OR. We had been off and on heparin. We put her back on heparin. I took her back. Yeah. We had the duplex. I mean, duplex showed whatever it was as pre-op. There was some issue, but not too bad. This one, when the acute effect occurred, that's the time when we did the angio, and I had to take her on that day. So when I took her, look at the angio. So I had to do thrombectomy. It looked like there was still some thrombus, so we did angiojet. This is the peroneal. I tried to open peroneal. 80 is there. So I kept on following. I couldn't open peroneal fully, but I had to go back and forth. Ultimately, after working hard, I was able to get 80 into DP down to the foot. So now I'm happy, okay? I opened up the left leg, which is not the leg that had the iliac rupture. So now the circulation is all the way down. When I finish, she has palpable pulse. She's good. So we thought, okay, now poor lady would be good. She would be walking on her own. 4 hours later, after all these things, TPA, angiojet, all the cleaning, everything, palpable DP pulses, in the recovery room, she loses her pulse and leg gets cold again. Her platelet count dropped down to 50. So now we are thinking it's probably HIT syndrome at this point. So again, we talked to the family, we took her back to do the embolectomy because she had palpable pulse. I had the angiogram, which clearly showed good results. So this is what we found. We opened it up. We did the embolectomy, and you can see the plug that comes out. We stopped her heparin. We put her on argatroban, and we did the completion angio. After we did this again, we reestablished the flow back to normal. So now this lady has a flow, but at this point, she already has quote-unquote HIT syndrome with platelets of 50. So we had started her on argatroban, and fast forward, a few days later, I mean, at this point, she did maintain her perfusion to the ankle, but the foot outflow vessels were pretty gone. So we had to tell the family that at this point, would you do anything different? other than just observing. So 3 days, 4 days later, we did get the antigen and ELISA test. Both were positive. So she definitely had heparin-induced thrombocytosis and thrombocytopenia, as well as thrombosis, which is very unusual. This was her leg at this point. So ultimately, we had recommended that she would end up losing her left leg. So she ended up getting an amputation on the left. She is alive at 96 in her wheelchair, but she is traveling, going around. Would anybody have done anything different? The key questions were...
Well, when you look at this,
Can I say something about this case? Because I think you're fabulous to show it to us. And I admire the fact that you treated her. While you were showing us, however, her thoracic aorta, I was thinking, I want to see the access. And I think that the moment this case went down is because sometimes we underestimate the severe disease in a 90-year-old's arteries in the access. And the angiograms can look quite good. But as a surgeon who sees and feels them, particularly when it goes wrong, you think, wow, that was much worse than I thought it would.
Exactly, but again, to the point that it's a very valid point. Retrospectively, we all think, but the fact that you can put 22 sheath, not once, not twice, not 3 times, 4 times, and then the 20 French sheath, the next one that you put for balloon dilatation, gets stuck. So it could be spasm, because we all know when you're pushing something in, if you have resistance, you and I will not progress. You will think, okay, I can either do extension, I can put an iliac extension and do the stent deployment. So for her age, I mean, it is definitely a concern and question, because at 90, you really don't want to start doing more than what's necessary, but at the same token, you don't want to do less and get into trouble. So in this question, I mean, it's only after the fact that you start thinking which way was the right way. And 22 French sheath would not have gone up 4 times. It was a surprise, but again, the fact is that the right leg had no issues. It's the left leg, because she got heparin-induced thrombocytosis, and that could have occurred for any reason. I mean, that had nothing to do with what happened. Yes, there was exercise complication, which was appropriately handled, but then she developed this, and she is alive at 96. Anyway.
good job, Nilesh.